Okay. Hello. I'm Mary Buffington. I'm a nephrologist here at LSU. And I am going to talk to y'all today about diabetic nephropathy. And I do not have any conflicts of interest. And I would like to start with a definition, which is not as easy as it sounds. Okay, so the person has to have diabetes. They have persistent albuminuria of more than 300 milligrams a day, so that's macroalbuminuria. And they will have, and it's not part of the definition, but ultimately they will have clinical manifestations of a decline in a GFR, hypertension. And also you have an absence of clinical or laboratory evidence that the patient has some other cause that could be causing the proteinuria. Diagnosis is with urine albumin to creatinine ratio. Normal is less than 30 milligrams in 24 hours. You can also have moderate albuminuria or microalbuminuria, which is 30 milligrams per day to 300 milligrams per day, or severe albuminuria or microalbuminuria, which is more than 300 milligrams a day. Now you can have an elevated urinary albumin to creatinine ratio independent of kidney damage. It's in a situation where you've been exercising within 24 hours or there's an infection or fever or sometimes CHF or marked hypertension or hyperglycemia can cause it. So you will probably want to check the urine albumin to creatinine ratio. Take 2 to 3 of them over 3 to 6 months just to confirm that the patient actually does have albuminuria. Now with diabetes, you get microvascular complications and macrovascular complications. And the microvascular complications are diabetic retinopathy, diabetic nephropathy, and neuropathy. And the macrovascular are stroke, heart disease, and peripheral vascular disease. So we will mainly be talking about the microvascular complication here. So the prevalence of diabetic nephropathy, of diabetes in the USA is about 21 million people. And type 1 diabetes accounts for 10% of those. And of those persons with a history of diabetes, roughly 43% will have microalbuminuria and 8% will have macroalbuminuria. And diabetic nephropathy is actually the leading cause of end-stage renal disease worldwide in the developing world. So about 50% of end-stage renal disease patients will go on dialysis because of diabetes-related kidney disease. And diabetic patients with end-stage renal disease will have a 1.5 to 2.5 time increased mortality because of the cardiovascular, increased cardiovascular risk that they have. Now to talk about epidemiology, I wanted to kind of give you an idea of not just the prevalence and incidence, but kind of the course of the disease. So we're going to go through a few slides to kind of go over that. Looking at diabetes type 1, I'd like to talk about this DCCT edict study, the Diabetes Control and Complications Trial. That was a trial that was from 1983 to 1993. They compared 2 treatment strategies for type 1 diabetes. In one arm, it was intensive therapy, where they educated the patient about self-monitoring the glucose and giving multiple insulin injections throughout the day. The other arm was a conventional therapy, which was the standard of care at the time, where they often would not even monitor their home blood glucose, and they would give maybe 1 insulin injection a day. So in the intensive therapy arm, during the active part of this trial, when they were undergoing the active therapy, intensive therapy had a hemoglobin A1C of 7.1% on that arm. And then conventional therapy had an A1C of 9%. Okay, so the intensive therapy was much better at controlling the glucose, and they had much better cardiovascular outcomes. The number of patients was 1,441. after the active randomized trial was over, they continued to monitor those patients as a cohort, okay? And they called it the EDIC cohort. And for this trial, they added another kind of local Pennsylvania cohort of 161 patients to look at this data over a period of time. And this is the cumulative incidence of proteinuria and cardiovascular complications. So this is the conventional therapy. This is the EDC arm, which you can sort of consider together with this, and this is the intensive therapy. So you can see with the conventional therapy, the microvascular and macrovascular changes risks were much higher. Okay, the incidence of these events was much higher, and this. Let me say that once the actual randomized part of the trial was finished, essentially they wanted to continue as a cohort, and so the intensive arm, they no longer got their insulin glucose supplies from the monitor. They didn't have the direct intervention. Their glucose control was monitored by their primary care physician. So their hemoglobin A1C kind of drifted up to the 7 range over the course of the 10 years after that randomized part. In the conventional therapy, they educated the patients. They told them it was important to monitor your glucose and have better glycemic control, and so their A1C actually improved from 9 to 8, okay? So at this point, when we're looking here at this, the results in 2009, you see the conventional, actually, even though they had a comparable A1C of 8, the advantage to that intensive control over those 10 years with the hemoglobin A1C around 7 was still persistent over that time frame. So you see the risk is higher in these conventional versus the intensive. Now, another reason I wanted to point this out to you is because there are a lot of studies that talk about the epidemiology, the incidence of diabetic nephropathy, and some of them were done, quite a few of them were done before the more intensive therapy was done, okay? So their incidence will be higher than more recent studies. And this is just to give you kind of a contrast. So if you have a patient who is able to have better glycemic control, you can expect outcomes like this: proliferative retinopathy 21%, nephropathy 9%, cardiovascular disease 9%. However, if they're less well controlled, you're not going to be able to get those numbers, and it'll be more in line with this group, okay? And even though they had all of these subjects in the study, they only had renal insufficiency in 36 subjects. So that was interesting. And they defined nephropathy as having the 300 milligrams per day proteinuria or increased creatinine. So continuing with diabetes type 1, there was another study done that looked at that same cohort and it was published in 2014, that same cohort of people, following them along. And they wanted to look at what happened to those patients who developed macroalbuminuria during that trial, okay? There were 159 of those. They were followed for 9 years for a maximum of 25 years. And at the time of the macroalbuminuria diagnosis, the mean age was 37. They had a mean albumin excretion ratio of 524 and a mean GFR of 108, okay? So 10 years later, looking at how they were doing, 52% of those had a sustained reduction in their proteinuria to below 300 milligrams a day, mostly because of RAAS inhibition, okay? Now 32% had a sustained GFR less than 60, and 16% developed end-stage renal disease. So you can see that this proteinuria, it can wax and wane, and it can get better and get worse, okay? There was a reduced risk of impaired GFR in patients with a lower A1C, better blood pressure control, and better control of their proteinuria. And having the macroalbuminuria was associated with a 50-time increased risk of developing a GFR less than 60. So that's a big risk. So the cumulative incidence of macroalbuminuria at 25 years after diabetes onset was 6% in the intensive therapy group and 17% in the conventional therapy group. So that's diabetes type 1. And we can look at diabetes type 2, where we have the UK-PDS 64 trial that looked at the data from the UK-PDS study to examine the development and progression through the stages of type 2 diabetes. Okay, there were 5,097 subjects, and they looked at the annual, one of the things they looked at was annual probability of transition from stage to stage. So they started out and they had people with fairly low protein levels. 92.7% of these patients had no albumin, microalbuminuria, and 6.5%. Very few had macroalbuminuria. And so looking at year rate of progression, which is what will be their rate of progression from the stage they're in to the next stage. So if they had no albumin, they had a 2% rate of progression to the microalbuminuria stage. And so people with microalbuminuria, they had about a 2.8% rate of change advancing from microalbumin to macroalbumin, okay? And then the macroalbumin had about a 2.3% chance, okay? But see, if they had a lower creatinine, then their chance of worsening was very high, okay? So the 10-year prevalence, at 10 years, the prevalence of microalbuminuria was about 25%, macroalbuminuria 5.3%. And very few had advanced to the CKD part. Then looking over here at the annual death rate, you have in no albumin, it's pretty low. Microalbumin, it goes up a little bit. But the death rate here in the macroalbumin, it actually is higher than their rate of progression. So they're more likely to die than progress to the next level. So these are significant risks here. And then you can see in the CKD arm, it's 19.2% annual rate of death. So that's pretty high. There was also a study from Japan looking at about 200 subjects with type 2 diabetes and microalbuminuria, and they wanted to look at if you could decrease proteinuria in type 2 diabetes, and patients were evaluated once every 2 years for a total of 6 years, so they had 3 evaluations. And then the result was a 6-year incidence of remission in urine albumin excretion to a normal value and 51%. So more than half of the people were able to improve to not have microalbuminuria anymore. 6-year incidence of regression or a 50% reduction in urine albumin excretion in 54%. And a frequency of progression to overt proteinuria in 28%. And the factors associated with the decreasing proteinuria were microalbuminuria of short duration, they didn't have it for very long, RAAS blockade, lower A1C, and a lower systolic blood pressure. And the reason that it's important to look at microalbuminuria is because having microalbuminuria actually correlates with a decreased survival. Okay, so microalbuminuria of 4 to 200 micrograms per milliliter had a hazard ratio of 2.28. So, it's important to, modify those risk factors as possible and improve survival in our patients. So the pathology of diabetic glomerulopathy is, you have glomerular basement membrane thickening, you have mesangial expansion, arteriolar hyalinosis, and you get a podocyte injury and glomerular sclerosis. And so looking here, this is a normal glomerulus with open capillaries, and you can see about 2 mesangial cells for each capillary. And then over here, this is diffuse nodular sclerosis, and you can see this mesangial expansion. And these are, it's a nodular expansion with kind of the nuclei, the cell nuclei surrounding it. So you have the nodular glomerular sclerosis and just the dense appearance of these deposits. And here you also have diffuse nodular mesangial expansion, and also in this vessel here, you have hyaline thickening of the arteriole. And this is showing just the mesangial expansion like before, and this is a fibrin cap, which is kind of an accumulation of glycosylated proteins in between the glomerular endothelium and the basement membrane that is also causing damage. So there are other causes of nodular sclerosis. So you would want to exclude those if you come back with a report of nodular sclerosis. You can have that in amyloidosis, monoclonal light chain diseases, glomerular deposition diseases like fibrillary and immunotactoid. Some cyanotic congenital heart diseases and cystic fibrosis can have it, and other glomerular processes. So looking at the natural history of diabetes, essentially at time 0, when they have the disease, you have a normal amount of microalbuminuria, normal amount of protein excretion, and a normal GFR. And as the disease progresses, you are having changes going on with the kidney and other, you have other microvascular changes going on too. So at the point where you have onset of nephropathy, then you have a hyperfiltration. You have an increase in the GFR because the kidney is hyperfiltering. You still have, sort of a reasonable rate of proteinuria there. So as you're going from 5 to 10 years, you're still having the hyperfiltration, but the disease is advancing. And it is pretty rare to have overt proteinuria before 10 to 15 years. So you can see how at 10 to 15 year mark, it really spikes up. The proteinuria spikes up, and you see a decline in the GFR over here. And then as the proteinuria goes up, the kidney function goes down, and then you can approach end-stage renal disease. And so that's sort of the way that the disease progresses over time. But also it's a very long time frame that we're looking at. It's not a short time frame. So the pathophysiology of the diabetic nephropathy is glomerular hyperfiltration, hyperglycemia, and advanced glycation end products play a role. Cytokines like VEGF and pro-fibrotic and inflammatory mediators play a role. Also, there's it looks like a decrease in nephrin expression may be involved, and impaired podocyte-specific insulin signaling. So with hyperfiltration, you have an elevation in GFR early in the course of diabetic kidney disease. You get glomerular hypertrophy, and an increased renal size can occur where the kidneys actually enlarge. You can get an intraglomerular hypertension and dilation of the afferent glomerular arteriole that increases the blood flow, increases the pressure in the glomerulus. And they looked at development and progression of renal disease in a group of Pima Indians. And these were Indians that were prone to develop type 2 diabetes. And they saw that patients with a normal glucose tolerance test had about a GFR of 123. But when you looked at people with impaired glucose tolerance test or with newly diagnosed diabetes, or then when you look at the patients who've had diabetes for 5 years, you can see you see a progressive increase in their filtration. So the GFR is going way up. And so you have, for the newly diagnosed patients with diabetes, GFR of 143. For the patients with diabetes for more than 5 years, it's 153, and that's tremendous GFR, so they're definitely hyperfiltrating. So hyperfiltration is the failure of autoregulation of the renal perfusion pressure. And the autoregulation consists of a myogenic vascular response at the afferent arteriole and also tubuloglomerular feedback. So the myogenic response is as the vascular smooth muscle cells stretch, that causes a depolarization of the membrane and a calcium influx, and then that leads to contraction of those vascular smooth muscle cells at the afferent arteriole. So with the stretch, you have a constriction and a limitation of the flow into the glomerulus. The tubuloglomerular feedback is where at the macula densa, where the thick ascending limb meets the distal convoluted tubule, you have the macula densa cells, and those sense sodium chloride concentration in the tubular fluid. And then through a series of, the adenosine is released that results in vasoconstriction of the afferent arteriole. There's an increase in calcium in the vascular smooth muscle cells. There's a decrease in renin, and the afferent arteriole vasoconstricts. So these two things can work together, okay, to regulate the pressure within the glomerulus. Also, if you have a decrease in the sodium chloride in the tubular fluid, it has the opposite effect, because you are not getting that signal from the juxtaglomerular cell, and so you are actually vasodilating. Okay, so you have a vasodilatation of the afferent arteriole that increases the flow into the glomerulus. So the cause of the abnormal dilatation, it can be insulin-like growth factor 1, atrial natriuretic peptide, sometimes an intracellular accumulation of sorbitol can be involved, glycation products, and also tubuloglomerular feedback, where you have the increased proximal tubular reabsorption of sodium that via the SGLT, sodium glucose cotransporter 2, that causes an afferent arteriolar vasodilatation. So hyperfiltration, with the afferent arteriolar vasodilatation, you have a glomerular hypertrophy and hyperfiltration, and an increased filtration pressure and stress on the podocytes. And I don't think you can see that very well. Let's see. Well, this is essentially what I'm talking about. Here's the macula densa, and essentially you have the afferent arteriole has the sort of controls the flow into the glomerulus. This is under normal pressure. The efferent arteriole is under the control of the angiotensin II, and so this is normal pressure. When you have diabetes, you have an vasodilatation of the afferent arteriole, and that increases the pressure and puts stress on the podocytes. When you have RAAS inhibition, that actually vasodilates the efferent arteriole, so that can relieve some of the pressure into the glomerulus. But also, if you look at the SGLT2 inhibitors, that can inhibit the reabsorption of sodium and glucose here. You deliver more sodium to the distal tubule here, and then you have an increased signal to this afferent arteriole to vasoconstrict. So that is another way where you can try to return this glomerulus to normal perfusion pressure and avoid the hypertension and the damage and stress on the podocyte cells. Hyperglycemia is also a cause, an important cause in the pathophysiology. It stimulates the mesangial cell matrix, can lead to mesangial cell apoptosis and mesangial expansion. You get glycation of tissue proteins, activation of protein kinase C, and upregulation of heparinase expression. So advanced glycation end products are formed when you have excess glucose in hyperglycemia, and that combines with the free amino acid on proteins. And those can be circulating or they can be fixed in tissue. And that's a non-enzymatic process that occurs that forms early glycation products that are reversible, and over time they become irreversible. And increased circulating glycation in products in diabetes can cross-link with collagen, and they're implicated in the microvascular complication. Excuse me. So risk factors for diabetic nephropathy are genetic susceptibility, age, elevated blood pressure, GFR, glycemic control, race, obesity, smoking, and contraceptives. So they've done some genome-wide scan studies, and they have not found one in particular gene or gene region that they can point to that's responsible for diabetes or diabetic nephropathy in particular. But they have found in some very limited populations, they found some genes or some gene regions that may be involved, but there's no particular gene or region that we can point to when investigating diabetes. So referral to a nephrologist, when would you want to do that? In all patients, if the patient has diabetes and proteinuria and their GFR is less than 30, I would say definitely refer to a nephrologist. But also, if the GFR is 45 to 60, you can refer to a nephrologist if there's a possibility that the patient has non-diabetic kidney disease. Now, I know here people refer much earlier, and that's really good. These are the ADA guidelines on when to refer to a nephrologist, but we're happy to be part of that treatment much earlier than that. So when would you be looking for a non-diabetic renal disease in this higher GFR? Clues for that is if the onset of proteinuria was less than 5 years from the diabetes type 1 diagnosis, because it takes at least probably 10 to 15 years for them to develop that degree of proteinuria. If they have the acute onset of renal disease with a rapid decline in GFR, that would be concerning. If they have active sediment with red cells or cellular casts, if there's an absence of retinopathy and neuropathy and diabetes type 1, and they're still having proteinuria and loss of kidney function, signs and symptoms of another systemic disease like lupus or something like that. And if there's a significant reduction in GFR within 2 to 3 months of ACE inhibitor initiation. Also refractory hypertension or abnormal findings on a renal ultrasound. So treatment that preserves renal function is antihypertensive therapy, and in diabetes type 1, ACE inhibitors are recommended, and blood pressure control definitely preserves renal function. Also protein restriction and salt restriction can preserve renal function. Other things that can reduce protein excretion are RAAS blockade, mineralocorticoids, diltiazem or verapamil as a calcium channel blocker, salt restriction, weight reduction, hyperlipidemia, or intensive combined therapy. So with hypertension, there are several guidelines out there. What should be the goal hypertension that you have for your patient? JNC8 has a target blood pressure of less than 140/90 in diabetics of all ages, any level of protein, and any degree of CKD. So the KDIGO guidelines issued in 2012 looked at adults with diabetes and CKD, and they said that with the urine albumin creatinine ratio less than 30, the target would be less than 140/90. But with the microalbuminuria or macroalbuminuria, they would recommend a target of less than 130/80. And the ADA consensus statement on diabetic kidney disease in 2014 has the same for the no proteinuria, but on proteinuria more than 30, they say there's weaker evidence for the less than 130/80, but you can consider it. And one of the main things they indicated that they emphasized was that to keep the diastolic blood pressure over 70, because there is a concern of decreased perfusion and decreased kidney function with and also, you know, cardiovascular issues if you have a lower diastolic blood pressure. So looking at the first line drug of choice for diabetic nephropathy is RAAS inhibition, and then JNCH as ACE inhibitor or an ARB is a first line drug. KDIGO says ACE inhibitor or an ARB, but they say that diabetes with albumin creatinine ratio 30/300, you can choose either an ACE or an ARB, but for urine macroalbuminuria, there's strong evidence for an ACE inhibitor in diabetes type 1 and an ARB in type 2. And they do not recommend a combination of the ACE plus the ARB. And it's essentially the same in the ADA conference consensus statement. No combination ACE and ARB, and they don't recommend aliskiren with a RAAS inhibitor. They don't recommend a renin inhibitor with RAAS inhibitor. So looking at sodium glucose cotransporter 2, this is expressed in the proximal tubule. It mediates reabsorption of 90% of filtered glucose, and it reabsorbs sodium and glucose at a 1-to-1 ratio. So in diabetes, the hyperglycemia really activates this receptor. So you're reabsorbing a tremendous amount of glucose and sodium. So with that, so you are having a decreased delivery of sodium chloride to that distal tubule. So that signal to vasodilate or vasoconstrict the afferent arteriole is missing, okay? So one advantage of the SGLT2 inhibitors is to block the reabsorption of glucose at the proximal tubule. You will lose glucose, you know, through urinary excretion, and that's a very mild, you know, it's not a very powerful it's not a very powerful treatment for the hyperglycemia, but it does decreases the sodium reabsorption and increases the sodium chloride delivery, which can change the renal hemodynamics in that glomerulus. And there really is a reason I'm telling you that. So there was a study of this SGLT2 inhibitor, Empagliflozin. It's a selective inhibitor that was approved for type 2 diabetes, and it is as an add-on or a monotherapy, and it's for CKD stages 2 or 3A. Okay, so the GFR needs to be greater than or equal to 45. So its associated clinical effects are you can have some weight loss, which is great for diabetic patients. You can have a reduction in the blood pressure without an increase in heart rate. There are some, you can actually have an improvement in albuminuria, and there's just a very, very, very small increase in the LDL and HDL. One of the recurring side effects of this drug class is urinary tract infections and genital infections. So you do see some of those. So this is a study. There's a randomized controlled trial, double-blind, placebo-controlled, and it looked at cardiovascular events in patients with type 2 at high cardiovascular risk, and they were on standard care for glycemic control. Okay, they had to have a GFR greater than or equal to 30 milliliters per minute per the MDRD equation. And they had 3 arms. They had a placebo arm, and then they had 2 arms with the Empagliflozin, one with 10 milligrams a day, the other with 25 milligrams a day. And they were the patients were well treated with antihypertensives and lipid lowering therapy. So the primary outcome was a composite outcome of death from cardiovascular disease, non-fatal MI, non-fatal CVA. And the secondary outcome was all those things in the primary outcome plus hospitalization for angina. And they looked at a lot of these things just, they separated them out too. And So that essentially they had pretty good results here on their primary outcome. The patients in the Empagliflozin group had a lower, a lower incidence of these events, and so with there's an advantage, a hazard ratio of 0.86 here for superiority of Empagliflozin over placebo. Okay. Death for cardiovascular events, there's also an advantage here, a hazard ratio of 0.62. Death from any cause, an advantage, hazard ratio 0.68. And then hospitalization for heart failure, the Empagliflozin group did better with a hazard ratio of 0.65. And then looking at the glycated hemoglobin levels, this is the placebo group, and the Empagliflozin group did a little bit better. And interestingly, the 10 and the 25 were kind of very similar here. Okay, so not a wide separation between those two dosages. So adverse events were UTI and genital infection, and there was no increase in renal failure or acute kidney injury during this trial. And some of these, some other drugs in this drug class had been noted to cause acute kidney injury, but there's no acute kidney injury in this, and the renal function was maintained. Okay. There were similar adverse events between the two groups relating to diabetic ketoacidosis, hypoglycemic events, thromboembolic events, bone fracture, and volume depletion. So that shows that in patients who are at high risk of cardiovascular, already have cardiovascular disease, that essentially these patients, the Empagliflozin may be a good option for add-on treatment of their diabetes. But they took that data that they had and they wanted to do a secondary analysis and looking at renal function. So there was another study published at the end of last year looking at Empagliflozin and progression of kidney disease in type 2 diabetes. And so they had actually separated, in the initial trial, they had separated into two groups, one with a GFR less than 30, one with a GFR less than 60, and one with a GFR 60 or greater. And then the secondary outcome was a composite microvascular outcome that they actually were collecting data for during the initial trial. And that was initiation of retinal photocoagulation, other kind of retinopathy sort of endpoints, and also incident and worsening nephropathy. So they defined that as progression to macroalbuminuria, doubling of serum creatinine with a GFR less than 45, initiation of renal replacement therapy, or death from renal disease. So looking at this, incident or worsening nephropathy, actually the Empagliflozin group was better than placebo, hazard ratio 0.61, and looking at their composite of doubling of serum creatinine, initiation of renal replacement therapy, the Empagliflozin group was also better with hazard ratio 0.54. And looking at these outcomes, you can see that all of these incident or worsening nephropathy, cardiovascular death, progression to macroalbuminuria, doubling serum creatinine, and they favor the Empagliflozin. Okay, so looks pretty good. Now this is looking at change in GFR over time, and you can see that when the patients first begin the Empagliflozin, they are beginning that hemodynamic process of blocking the SGLT2 receptor, so they're delivering more sodium chloride to the juxtaglomerular apparatus, and that will lead to vasoconstriction of the afferent arteriole. So it's essentially decreasing the pressure in that glomerulus with this medicine, okay? So you can see that here when the GFR goes down. but it sort of rebounds, and then it remains steady over here, okay? Kind of takes a dip. And then you can see just the drug-wise, this 25 milligrams sort of dips down right here. But once you get to here, it's actually better than placebo, okay? Now, this was interesting. So this is at baseline, the GFR for placebo, this is the bottom one, and the 10 milligram and the 25 milligram Empagliflozin, okay? So over time, the GFR goes down here, and then the GFR goes down with the placebo, okay? Well, here, this is the end of the study. So when they take them off the SGLT2 inhibitor, okay, then they recover renal function here, okay? So it's just a functional decline in GFR. It's not a structural decline in GFR, okay? So here's their GFR at baseline, and this is pretty close. I mean, there's not that big of a change over all this time, and you can see what's happened to placebo. Placebo over here, it doesn't have that rebound. So there have been some changes going on in that kidney in the placebo that were not compensated for by this medication, and so it seems like he didn't really have that advantage there. So looking at just the class overall, it's a weak glucose lowering agent. It reduces A1C by 0.5 to 0.7 percentage points. It should not be used in type 1 diabetes, and there are other adverse events. Empagliflozin has a lot of incidents of bone fracture, but looking through the reports, it looks like that could be that because of the volume depletion that you kind of get with this, with the osmotic diuresis, there may be hypotension involved that causes people to fall more frequently. At this time, it's not known if these inhibitors reduce bone mass. That needs to be studied further. But you do have an increased number of bone fractures with this medication. Also, as a class, they have the genitourinary infections. Okay, so there is after the other two medications, not empagliflozin, but dapagliflozin and canagliflozin, there have been post-marketing reports of acute kidney injury. That really probably relates to intravascular volume depletion. And so it's very important before you put a patient on this to assess their renal function and also to assess their volume status. And continue to monitor their renal function and volume status while they're on the drug. And caution in patients who are predisposed to volume depletion, and also caution for those patients taking medications that can affect volume status or kidney function, like diuretics or NSAIDs or something like that. And then with this medication, essentially you want to avoid use if the GFR is less than 60, and this is, I think, Invokana. Avoid use in GFR less than 45, and then you have a dose adjustment for, a GFR 45 to 59. But anyway, I just wanted to kind of review diabetic nephropathy and go over these really interesting drugs, SGLT2 inhibitors, and it's kind of a potential to address the actual physiologic damage being done in the glomerulus. And we can see what an advantage the RAAS inhibition is, and it may be that this SGLT2 inhibition may also turn out to be a pretty good thing if we can manage all the side effects and everything like that.
I have a question.
Okay.
In the studies on SGLT2 inhibitors that you cited, were the patients also taking RAAS inhibitors?
They were.
In both arms? In the placebo?
And it's actually, in the literature, it's really not recommended that you do that, but they were in the studies.
So,
not every single one of them, but there were people on that.
So in the placebo arm, there was no improvement in kidney function, but they were still on their RAAS inhibitor.
They weren't taken off of that.
Is there any risk of combining those two? Were there any cases of
It's not
acute renal
recommended.
failure? Combining, because now you're having afferent vasoconstriction and you're having efferent vasodilatation, like a double whammy.
A double whammy.
Yeah. But there were no cases of
We don't have cases. There's not, this acute kidney injury thing hasn't been in the studies. It's like an FDA thing. So essentially, you can go to the FDA website and they kind of say the same thing over and over. And they'll say, you know, we think that this was an acute kidney injury. We think it was from volume depletion. You know, monitor your patients for volume depletion. You know.
No, because in I think that was the Veterans Administration trial, the combination of ACE and R clearly showed increased acute renal failure and increased hyperglycemia, you know, and with no benefit on the progression of renal failure. So I think after that, everyone stopped using the combination, you know, as for renal protection. So in this trial, they didn't have any episodes of acute renal failure. They would have mentioned it if they had.
Well, yeah, there was no difference between the groups. But that's a great point about the dual blockade with the RAAS and the R. Oh, I mean with the ACE and the R.
Thank you.
Well, you're welcome. Thank you.